Welcome, everybody, to the first inaugural IBD Insider Patient Updates program, coming to you from the 3rd Annual Crohn's and Colitis Congress. My name is Dr. Uma Mahadevan, and it is my privilege to have been the co-chair of the Congress with Chair Dr. David Rubin. We understand the importance of patient and caregiver education. The Crohn's and Colitis Congress is the premier IBD-specific educational congress for physicians, researchers, nurse providers, physician's assistants, nurses, and other IBD health professionals. The IBD Insider program is designed to provide patients and caregivers with key insights and information from the Crohn's and Colitis Congress, with an emphasis on adapting the information to the patient and caregiver audience, ensuring key messages and takeaways are highlighted at the end of each program, providing definitions where needed to facilitate learning, and highlighting tools, resources, and discussion guides at the end of each presentation, encouraging patient and provider decision-making. We use what's learned in future discussion. You can use what's learned in future discussions with your care team. The program format, there will be 3 types of presentations. There will be treatment updates, quality of life updates, and Congress highlights. Each presentation will be approximately 20 minutes, followed by 10 minutes of moderated questions and answers. Presentations have been posted on the IBD Insider webpage and include program slides, definitions, and links to the Crohn's and Colitis Foundation and the American Gastroenterological Association resources. To download the slides and resources, visit crohnscolitisfoundation.org/IBD Insider. Questions were collected prior to today's program. Moderators will be using these questions to begin the Q&A session. To submit a question today, please click on the bottom left-hand corner of your screen on the word Q&A and type in your question. During the Q&A portion of the presentation, we will select questions to be answered by our panelists. Remember, when asking questions, only ask one question. Keep the question general in nature. Do not include personal or specific disease details, and speakers will provide general answers. The answers provided should not be considered medical advice or guidance. Please follow up with your healthcare provider to address specific questions about your disease. Please note that while we will do our best, we might not be able to answer all submitted questions. I want to thank the Planning Committee for this first annual IBD Insider program. These include physician and patient volunteers, Tina Aswani Amprakash, Dr. Meena Butra, Aaron Blocker, Dr. Rajiv Jain, Dr. Jamie Kanukin, Dr. David Rubin, and Amber Tresca. Additional thanks go out to the Crohn's and Colitis Foundation and the American Gastroenterological Association staff. And it's my pleasure to introduce the first speaker, Dr. Frank Scott. Thank you and enjoy the program.
Thank you, Uma, for the introduction, and thank you to the Congress and to the Crohn's and Colitis Foundation and AGA for the opportunity to speak. So I'll be talking about treatment updates in inflammatory bowel disease, what therapies we currently have available, how we select them, and potential future directions for therapy. This is my disclosure slide. So what we'll discuss today, just an overview of all the topics that we'll be covering. It'll be a fair amount of ground in a short period of time, so understand if there are questions. We'll review the currently available medications. We'll discuss how we identify which patients we're going to select which medications for. Once we started therapies, we're going to discuss how we monitor patients and the importance of monitoring patients after we've initiated therapies for them. And then touch briefly on how we're using drug monitoring or levels of the medications that we use to optimize their benefit. And then lastly, touch on briefly on some future directions of research that are pretty exciting. So it's been a sort of a whirlwind of development for inflammatory bowel disease over the past 20 years, going from initially just having corticosteroids and thiopurines and methotrexate to treat disease, to now having several different classes of biologic therapies for which we can treat inflammatory bowel disease. The first of these that was approved was Remicade, or infliximab. This was approved in 1998 for Crohn's disease, followed by Humira, or adalimumab, a drug that uses a similar mechanism of action, in 2002. And then for the next decade or so, we only had the anti-TNFs, and even though they were excellent medications, unfortunately, a large percentage of our patients won't respond to them. In 2015, however, we had the FDA approval of vedolizumab, which is our first novel mechanism of action for both ulcerative colitis and Crohn's. And then in 2017, ustekinumab, which employs a different pathway or mechanism of action. What's exciting is that this is just the tip of the iceberg, and there are multiple other medications, both within the classes that we'll discuss here and outside of those classes that will be coming available soon. These medications mostly target multiple pathways within the immune system. The anti-TNF biologics block a protein called tumor necrosis factor alpha that white blood cells use to activate each other, whereas the drug ustekinumab or Stelara attacks a slightly different, or blocks a slightly different signaling pathway. Whereas the drugs vedolizumab and adalimumab, Tisabri and Entyvio, affect how white blood cells get to areas of inflammation. And how those different mechanisms work influences how, in some ways, how quickly these medications are, how quick their onset of action is, et cetera. One of the first steps before we actually use one of these medications, however, is identifying which patients we should be using them in. There's data that show they clearly can potentially change the course of disease, reduce the need for surgery, hospitalization, or corticosteroid use, but we want to use them in our patients with moderate to severe disease or risk for moderate to severe disease over time, given some of their risks that they have. So through programs like the AGA's IBD care pathway, we have some criteria by which we identify those patients that may benefit from these medications. For example, high-risk features are thought to be diagnosis at a younger age in Crohn's disease, extensive involvement of both the small bowel and colon, the presence of perianal disease or deep ulceration, the urgent need for surgery soon after diagnosis, or the presence of stricturing and penetrating behavior. We have similar criteria through which we can identify high-risk individuals with ulcerative colitis, and those include those that present with a large segment of their colon involved at diagnosis or extensive colitis, those with deeper ulceration on their colonoscopy, a younger age of diagnosis, markers of systemic inflammation such as blood tests like C-reactive protein or anemia at diagnosis, frequent requirement of steroids. It's my general rule of thumb that more than one course of steroids in a year is an indicator that you should be considering advancing your therapy, or those that have a history of recent hospitalization or infection that may exacerbate their disease. Once we've stratified people by whether or not they're more likely to have a mild course or a more moderate to severe course, we can discuss what medications may be most appropriate. And we stratify what meds we're going to use based on this disease severity. For example, in those with mild Crohn's disease, the initial first-line therapy is often a steroid called budesonide. This is a unique steroid in that, unlike prednisone, it has something called a high first-pass metabolism. That means it's released in the small intestine. The blood from the small intestine goes to the liver, and the liver breaks down that steroid before it gets to the rest of the body, potentially reducing the risks of complications of steroids, such as fluid retention, osteoporosis, or abnormalities in blood sugar or hypertension. One medication that we don't use in mild Crohn's disease or in moderate to severe Crohn's disease, however, is mesalamine. So after an initial course of budesonide with mild CD, we're often just monitoring patients for recurrence of symptoms, which may be an indicator that they need more biologic therapy or small molecule therapy. In mild ulcerative colitis, we do use mesalamines, though there are multiple studies that show that they're of benefit. And we will often couple them potentially with colonic release budesonide, also referred to as Uceris, as an initial therapy. The mesalamines, however, alone are both effective for induction, which means resolving initial symptoms, and maintenance, which means maintaining that symptom resolution after it's occurred. Another class of medication that is available that we use still routinely in care are the immunomodulators, and these consist of two main classes. One is the thiopurines. These drugs are azathioprine and 6-MP, and the other is methotrexate. We'll often use these in combination with our other biologic therapies to modulate how those medications work. For the thiopurines, they have several different mechanisms of action, but they're thought to inhibit purine synthesis and induce T-cell apoptosis, or how T-cells die. They do have some side effects associated with them, but they're rare, and in the appropriate use, the benefits of thiopurines outweigh the risks for sure. But those risks are important to be aware of, and they include pancreatitis, lowering of blood cell counts, potential drug-induced liver injury, or lymphoma. Methotrexate is a folate analog that inhibits T-cell function as well. It's available as a pill formulation or an injection, depending on the dose. Long-term use is associated with fibrosis of either the liver or lungs. It can also potentially reduce blood cell counts, and it should not be used in women of childbearing age who are considering getting pregnant or who are not on birth control because it's teratogenic. As I discussed, the thiopurines do have some risks associated with them. I've already discussed pancreatitis, low blood counts, and liver injury. One of the other risks that all of our medications that affect the immune system potentially has is that of non-melanoma skin cancer. One of the recommendations that we do advise for patients that are on any of these medications is that they see a dermatologist every 6 to 12 months to have their moles and freckles examined and evaluated and potentially biopsied as needed. Again, even though this is a relatively rare risk, the benefits of these medications, when used appropriately, outweigh the risks. One of the newer classes of medications that we have are the biologic therapies, and these consist of 3 separate mechanisms of action, and that means that they affect different parts of the immune system. The first were the anti-TNFs, and this includes infliximab or Remicade, adalimumab or Humira, certolizumab or Cimzia, golimumab or Simponi. This was followed by the development of vedolizumab or Entyvio, which is currently available for both Crohn's and UC, and most recently by ustekinumab, which affects a different mechanism of action. It's also referred to as Stelara, which affects a different molecule for how white blood cells speak to each other. The anti-TNF agents, or anti-tumor necrosis factor alpha agents, that's your Remicade, Humira, come in several different formulations. Infliximab was the first available, and that's an IV infusion. That was followed by Humira, which is an injectable agent given usually twice weekly. That was followed by Cimzia, which is usually a monthly injection, and Simponi, which is also an injectable. These medications are generally thought to be safe, and they're very effective in treating Crohn's and ulcerative colitis, but they do have some adverse events it's important that you're aware of. They can cause infusion reactions or injection site reactions. They are immunosuppressive, so they do slightly increase the risk of infection. We're particularly concerned about hepatitis B and tuberculosis. There is a potential association with non-Hodgkin's lymphoma, a type of blood cell cancer, although in multiple studies that association seems to go back and forth some. And then there's some very rare adverse events such as drug-induced liver injury, drug-induced lupus-like response, and a syndrome that looks like multiple sclerosis that generally resolve when these drugs are stopped. The anti-integrin biologics were first approved in 2015 with Entyvio. There was a drug before that, natalizumab or Tysabri, that's still available for Crohn's disease. It's not used as often because of a really rare side effect that can occur when individuals have been exposed to a virus that most of us have been exposed to in our life. Entyvio, though, doesn't have that side effect associated with it, and it's approved for both Crohn's disease and ulcerative colitis. This affects a protein for how white blood cells get to areas where inflammation is already occurring. It's given as an IV infusion currently, but there will be an injectable formulation potentially available in the next year or two. It is very effective for both Crohn's and ulcerative colitis. Because it affects how white blood cells get to areas of inflammation, it doesn't affect the white blood cells that are already there as much, and so it can take a little bit longer to work. However, the trade-off for that is that it's also thought to be considerably safer and with limited risks of infection or hepatotoxicity, no clear documented association with lymphoma at this time. While we do advise skin cancer screening, that association is not well borne out either. The anti-IL-12/23 therapies I alluded to is ustekinumab, and there are several others in this class that are currently in development. This is unique in that it's a combination of an infusion and an injection. The first dose is an infusion, and 8 weeks later you start injections. And most patients will stay on every 8-week injections thereafter, although some patients require escalation to monthly dosing. Generally thought to be very safe. It was on the market for multiple years before being approved for Crohn's and ulcerative colitis, for psoriatic arthritis and psoriasis. So we have 5 to 6 years of follow-up data already on this drug, and it appears to be very safe, with the main risks or adverse events being infection and nasopharyngitis. With Entyvio, although we haven't seen a safety signal with regards to non-melanoma skin cancer with this medication, we do advise patients have an annual to semi-annual dermatologic evaluation to ensure that they don't have any non-melanoma skin cancer while they're using this medication. The newest therapy that's been approved, which wasn't on the initial figure, one of the JAK-STAT inhibitors. These are oral medications. The first to be approved in ulcerative colitis has been tofacitinib. This inhibits two proteins called JAK1 and 3, which are intracellular cell signaling molecules. As I mentioned, it's an oral delivery, so that's attractive for some patients. It has some interesting side effects, though, that sort of hamper our enthusiasm for it in terms of it appears to affect lipid levels, and the long-term effects of that aren't completely understood yet, although in the rheumatologic literature it appears that they may normalize or respond well to statin therapy. There is an increased risk of infection. In particular, we worry about shingles with this drug. And there's still the question of whether or not there's an association with this medication and clots in the legs or in the lungs. And that requires further research, but it has resulted in the FDA applying a warning for this medication that we use the lowest possible dose. Because of those risks and those questions, many providers, myself included, position this drug a little bit later in the treatment of ulcerative colitis, but it's still a highly effective therapy, particularly in severe ulcerative colitis, and it has a fairly rapid onset of action, which is pretty attractive for sick patients. So how do we choose these medications? It's an exciting time in that we have all these different therapies, but we actually don't have a ton of data available to help us decide which medication to use for which patient yet. And part of that is going to be a discussion with your gastroenterologist about what they feel might be the right drug for you. We have very limited head-to-head clinical trial data so far, and those studies the clinical trials that do exist comparing these drugs to placebo have very different patient populations, so it makes it challenging to compare them. The first head-to-head trial that we do have, though, just published, is called Varsity, and that compared adalimumab or Humira to vedolizumab or Entyvio in ulcerative colitis, and it found that Entyvio did have higher rates of clinical remission and mucosal healing, although there was some question as to whether or not there were reduced rates of steroid utilization for Entyvio versus adalimumab. It's exciting. There are multiple other studies like this currently being done, and I do think over the coming years those will help us define what medications we should use for which patients. In the interim, though, we have to use what data that we do have from the clinical trials to try to decide what medications work best for which patients. And most of that falls in the domain of what I like to refer to as in silico analyses. These are when we use the estimates that come from clinical trials to try to figure out where drugs might be best positioned, either by comparing them to the same placebo. On the left here, we have an example of what a network meta-analysis might look like, or through building simulation models, or what we refer to as Markov chain models, to try to figure out what combination or sequences of drugs result in the best quality of life. These do help guide us, and we'll go through some of the recommendations that some of the work that's come out of these analyses by other researchers like Sid Singh and myself in a slide or two here, but I did want to show you really briefly sort of what one of the results would potentially look like. This would be an example of a Markov simulation model, and it's measuring quality-adjusted life years at the end of 1 year. And in this model, we demonstrated at the end of 1 year that vedolizumab as a first-line therapy in ulcerative colitis may yield a modest benefit in comparison to using it a little bit later. So how do we choose the right drug using the available data? Well, for ulcerative colitis, this is some expert opinion. It's some combination of these meta-analyses and simulation models. But we consider infliximab and vedolizumab or Entyvio and Remicade to be viable first options. We tend to stratify which one of those medications we're going to use based on disease severity. Adalimumab is likely not an ideal initial therapy, although it's still an option for patients that have failed the other ones. And as I mentioned earlier, due to its risks, we tend to position tofacitinib or Xeljanz a little bit later after failure of initial therapies. For Crohn's disease, infliximab and adalimumab are the most commonly used first-line biologics. But as we gain more data about ustekinumab or Stelara, this may be equally or more effective as a first-line therapy and may actually have slightly improved safety profile over the anti-TNFs. And so when considering moderate to severe disease, you may want to use one for more severe patients and one for more moderate patients. Further research is required to assess that. Once we've started these medications, though, it's important that you follow up with your doctor. The idea is not that you are given this medication and the doc says, we'll see you in 6 months. We actually do want to closely monitor patients. And this is a slightly older, antiquated example of what we refer to as a treat-to-target algorithm. When patients are identified as having active inflammatory bowel disease, they're given one of these medications, with the idea of them being maintained on it after they've responded. And then they have follow-up at 3 to 4 months, and that follow-up consists of asking about their symptoms, if they've improved, to make sure that, for instance, in ulcerative colitis, they've had resolution of bleeding or decreased stool frequency or decreased abdominal pain in Crohn's disease, and usually some blood testing and stool testing in the terms of in the form of CRP or fecal calprotectin. It does also usually mean that there's going to be a follow-up colonoscopy at some point too, usually 6 to 9 months after starting these medications in patients that have had a clinical response, to make sure that not only are the patients feeling better, but that the actual lining of their intestines is healing as well. And if things are going well, then the follow-up switches to an every 6 to 12 month manner. Whereas if symptoms are increasing or not completely responding, or inflammatory markers are elevated or rising, we can more aggressively make adjustments to their treatment to get patients to where they're feeling better sooner. And we have good data now from a large clinical trial called the Calm trial that shows that this frequent monitoring every 3 to 4 months actually improves outcomes and can potentially improve mucosal healing rates, reduce clinical symptoms, and reduce the need for steroids and hospitalization. We also like to follow therapeutic drug monitoring, and there's some active debate right now about the timing and frequency and utility of doing this, but at least when patients are feeling well and have recurrence of symptoms, we should be looking at their levels. We know from the original clinical trials from drugs like adalimumab and infliximab that the concentration of these drugs matters, and that patients that have higher concentrations appear to respond better to the medications. For infliximab, we typically are looking at a concentration somewhere in the 7 to 10 range, and adalimumab, it appears it might be slightly higher. So you will want to discuss with your provider, particularly if you're starting one of these medications, when they would want you to have level testing done, and under what circumstances and what laboratory you would want to have that done through. There are occasionally issues with insurers covering this, so that's something we'll frequently ask the patient to look into beforehand as well. There are 2 different kinds of drug level monitoring. One is reactive monitoring. This is when patients present with new symptoms, and then we assess drug levels and antibodies. It's really useful for helping us figure out what the next best therapy is going to be when you've had new symptoms after being well on a medication. The other option is reactive or proactive monitoring. This is when patients are doing well, and we want to make sure that drug is perfectly dialed in so that they'll continue to do well. The data for the proactive monitoring is not as strong as for reactive monitoring at this time. There have been 2 randomized controlled trials that did not yield positive results, but there's a wealth of observational data that would suggest it may have some benefit, and so that's the area of active debate that I alluded to earlier. In addition to disease activity monitoring, we also like to monitor for other aspects of health while you're on these medications. And fortunately, through the Crohn's and Colitis Foundation and Cornerstones and other patient advocacy and education group, we have some tools to help us as gastroenterologists. But it does mean keeping up on your vaccination. We want to make sure that everyone gets their flu shot every year. There's 2 different pneumonia vaccines. It's important that you've had both and that they're given about 8 weeks apart, and you get a booster 5 years after that. There's a general recommendation that individuals that can have access to Gardasil for HPV vaccination do so. And individuals that may be at risk for shingles consider getting the Shingrix vaccination. I've had some difficulty with my own patients occasionally getting that because it's a relatively new vaccine, and on these immunosuppressive drugs we can't use the old vaccine, Zostavax, for shingles. In addition, we like to look at bone health, particularly if you've had a history of steroid utilization in the past, and that may mean a bone scan, depending on whether or not you were exposed to steroids, and vitamin D levels about once a year. And then we also advise patients, like I've alluded to multiple times, that they get their moles and freckles looked at. There's going to be some blood work that's going to be done on a regular basis to look at liver function and to look at blood counts to make sure the medications aren't adversely affecting that. And these recommendations may slowly change over time, so definitely discuss with your gastroenterologist about what appropriate healthcare maintenance screening that you should have depending on what medications you're on. As I mentioned, the monitoring after biologics is usually every 3 to 4 months until patients are doing well, and then it starts to spread out. At the very least, we should consider therapeutic drug monitoring for those that have lost response to medications, and many of us are using it in those that are doing well on medications to make sure they stay that way. And we want to prevent complications, so it's important to vaccinate, check bone health, consider cervical, skin cancer screening, colorectal cancer screening when you've had colonic disease for more than 8 years. And I did not mention earlier, but cervical cancer screening, in addition to the HPV vaccine, is very important, and we do recommend that patients that are on these medications follow up with their OBGYN for that. Just to touch base in the last minute or two here, regarding potential future directions, I personally get questions about this all the time from my patients. What, doc, I'm willing to consider these immunosuppressive medications, but what can I do from a dietary standpoint to help my IBD? And that makes, there's some reason why that would make sense. We all have certain foods that may exacerbate our symptoms to some degree or feel like they do. This is an area of active research looking at how the gut epithelial barrier and microbiome are interacting. It's a very complex system where the lining of the GI tract or epithelium, these cells are constantly sensing what bacteria are present through this mucin layer that exists along the lining of the intestine, and they're either tolerating or not tolerating the bacteria. And in inflammatory bowel disease, it's been shown that not only are the bacteria that reside in that mucin layer a little bit different than in individuals without IBD, but the immune response to those bacteria is one of the main causes of the inflammation that we see in the disease. There's been a wealth of information about the microbiome in association with autoimmune diseases over the last couple of years, and we're actively exploring that. We're also exploring how diet, which affects the composition of the bacteria in our GI tract, might also affect disease. And there's actually a prospective randomized controlled trial of dietary modification in Crohn's disease looking at just that, called DINE-CD, that's ongoing right now. So I can't make any strong recommendations right now. There are some weak effects in terms of diets that are higher in red meat or processed sugars that may exacerbate disease or promote inflammatory bowel disease, but these are weak associations in epidemiologic studies, and further research is required. However, stay tuned. So, key takeaways. The available therapies with new mechanisms of action have rapidly expanded over the past 2 decades, and there's going to be more of them in the next decade. The available biologic mechanisms include TNF-alpha inhibitors, the anti-TNFs, the anti-IL-12/23s, and leukocyte adhesion inhibitors. Biologic medications are the recommended first-line therapy for moderate to severe Crohn's and ulcerative colitis right now, and they have the potential to reduce rates of hospitalization and to reduce corticosteroid use and the need for surgery. And once you've started these medications, there's still follow-up that's required, and it's been demonstrated that frequent follow-up with laboratory monitoring and clinical symptom monitoring can promote longevity on these drugs, increase rates of mucosal healing, and potentially reduce hospitalization and steroid use. We have a few discussion questions for you to provide here with your healthcare team. This is more informational that you can, when you go to talk to your GI doctor about these, starting these medications, these are some of the questions that you'll want to talk to them about that are important. And then also we have a number of resources that are available from both the Crohn's and Colitis Foundation and American Gastroenterological Association for patients who want to learn more about their disease and how it's treated. Thank you for your time.
Thank you, Dr. Scott, for your presentation. But got a couple of questions here. So it says, in your presentation, you described that there are several different mechanisms of action for these drugs. You talked about it a little bit, but why is it important to have these different drugs that work differently?
That's a great question. Thank you. For a long time, we only had one mechanism of action, and that was the sort of anti-TNFs. And the unfortunate fact is that a significant proportion of our patients will not have a maintained response on these medications. And what we know from the original clinical trials of the second and third anti-TNF and fourth anti-TNF as they came to market is that once you've failed that first drug, your response to another anti-TNF, particularly if it's not because you formed an antibody against it, may be markedly reduced. And so having another mechanism of action or another pathway within the immune system to potentially inhibit has the potential benefit of a different treatment option with better benefits. The one example of this would be ustekinumab or Stelara, which appears to be sort of agnostic to whether or not you've been on an anti-TNF before.
And then if you had a crystal ball, where do you see IBD treatments going in the future?
Yeah, I think the sort of holy grail right now is figuring out what the right drug is for the right patient at the right time. We have all of these options, but what we don't have is great tools for stratifying which medication is going to be the drug for you. We see this in other fields of medicine, in particular oncology is way ahead of us in this. But at some point, I'd envision that we have similar assays, and there's some basic science research and some translational research that's starting to show that. When you would do a single assay that would say you should do this drug and not that drug, or you're the kind of person that would benefit from combination therapy as opposed to just a monotherapy with an anti-TNF. And there was some really exciting data presented at the conference this weekend that begins to show that. That is the future of the field, especially as the armamentarium continues to expand.
Which I think we're seeing too with the different mechanism of action where we're trying to get to that point.
Exactly.
Yeah. So we know, I mean, as patients, we know that any medication, anything we take comes with side effects. So how do you calm the fears of your patients about the potential side effects? How do you approach that with them when you're getting ready to start a new medication?
Yeah, I think that's another excellent question. I can prescribe these medications, but unless you are going to understand that it's the right thing to do, then the risks of missing medication doses and stuff can definitely increase and adversely affect care. And these medications are generally thought to be safe and effective, but the risks are real too, and it's important that we all understand what they are. So I try to step through each one. I describe not only sort of the relative risk, which is oftentimes how these numbers are expressed, but also the absolute risk. And I do like to use tools that sort of help the patient wrap their head around, what does a 5-fold increased risk of non-Hodgkin's lymphoma look like for a 35-year-old male? And so that they have a grasp of just how small of an event rate that actually is, even though the number 5-fold increase sounds like a big number. And then I just go through each of them, and it does take a little bit of time to sort of do this, but I think it's the appropriate sort of shared decision-making that's required before we start these medications so that we're both invested in the decision.
Okay. Actually, I think we have a question from some of our viewers.
Hi, so one of the questions we have is there genetic testing available to determine which therapy is most effective?
That does not yet exist, and that was what I was alluding to with regards to the sort of crystal ball question. We're starting to, we are at the beginning of having a few tests that may prove to be able to demonstrate, for example, whether or not you should be on a combination therapy or on a monotherapy, but we don't have a predictive test for which class of medications just yet. There's a lot of active research in that field, and that's where we're going, but we're not there yet.
Our live participant, Cynthia, asked, can you elaborate further on the transition from one biologic to another when one becomes ineffective?
Yeah, so it depends on what biologic you're on first. Normally, the first step would be to try to confirm that a patient has active inflammation, that their increase in symptoms is related to their IBD, and that may involve blood and stool testing and a potential endoscopy or imaging evaluation. Once that's confirmed, the next step is to make sure that patients haven't developed infection that can exacerbate symptoms, that we usually will screen for viruses or a stool infection called C. diff via stool testing. Once those two are done, then we have to look at why you are losing response to the medication that you're losing response to. If it's an anti-TNF, we would send anti-TNF levels and antibodies to make sure you haven't developed an immunologic response to the drug itself that's made it stop working. If that's the case, then you might be able to transition to another anti-TNF and have success with it. If you haven't developed an antibody and your drug levels are adequate, then we would want to move to something with a different mechanism of action. The actual sort of physical changing of drugs depends on what drugs you're on too. For some, I would want you to wait several weeks so that sort of drug washes out of your system, whereas for other drugs, we're a little bit more comfortable with just going ahead and getting started.
How can patients have progression of disease despite being in long-term remission on a biological therapy?
So that's a tough question. You know, we do think that over time, some patients may be able to, the actual inflammatory pathways that are involved in their disease may shift, and that may result in symptomatic worsening despite having initially been treated appropriately. I think other patients where there was a long-term chronic inflammatory insult may have resolution of their inflammation, but a pro-fibrotic cascade that results in scarring or stricturing may have developed, and we don't have great data that shows that our medications that are available currently right now can reverse that pathway. That's an active area of research by some other researchers looking at anti-fibrotic medications that may benefit as well.
All right. Let's see. We talked a little bit about the other treatment options, you know, but what have all of these new options that are come available, like what is that, you know, how has that impacted your clinic, like how you treat patients, like what kind of difference has it made to have all of these different drugs?
You know, I generally, we just have more medical therapies, so we have fewer patients that are requiring repeated courses of corticosteroids because we don't have any options left for them. I've personally found that I'm referring fewer patients to surgery. When surgery is indicated, it's appropriate and it should be done, and I do think sometimes we wait a little too long before making that referral. But that being said, I feel like overall the need for surgical intervention is decreasing over time as well.
One final question was, how long is it recommended to stay on a medication such as Remicade?
That's a great question. Usually the second question I get after what can I eat to fix my Crohn's disease. I advise my patients that I am optimistic when I'm starting one of these medications that they're still going to be on that medication 20 years from now. The unfortunate fact that I alluded to is that greater than 50% of our patients will lose response at some point to the medication that they're on. And we should do everything that we can to maximize the opportunity for them to have a prolonged response to the therapy that they're receiving. There are rare instances, and we're always hopeful that this happens, where their symptoms resolve, their inflammation resolves on endoscopy and labs, and we can have a sort of conversation about whether or not we could stop therapy or hold it and see what happens. But for that to happen, I'd want patients to be feeling normal, having resolution of inflammation, both on colonoscopy biopsies and on labs, for at least a year before I'd consider making that switch.
All right. Thank you, Dr. Scott, for your time. I think we're going to move on to the next session.
Thank you very much for having me.
Good afternoon, everybody. It is honestly a pleasure, and this is just one of those examples of when things don't go the way you thought they were going to go. You roll with it, and you practice some of your own stress management skills. One of the beauties of being a psychologist, a part of this program, is the opportunity to connect with over 1,300 of you around probably the world. And that's what's so special about the Congress, that we got the opportunity to see patient advocates and providers from really across the country and world coming for this reason of advancing the field of gastroenterology and how we take care of our patients. So I am Dr. Megan Reel. I'm a clinical psychologist, and I specialize in gastrointestinal issues. And I really have the pleasure today to work with Amber, who will be talking with me about a couple questions from you a little later on. I work as a GI psychologist at the University of Michigan, seeing patients with inflammatory bowel disease, as well as IBS and various chronic GI conditions. And today it is really my honor to talk about the ways in which psychosocial care has been addressed here at the Congress this week. I do not have any disclosures. So when we think about quality of life, we think about the ways in which nutrition, exercise, behavioral aspects of our health that include strategies for coping with having chronic illness, as well as other lifestyle therapies, all come together in the management of IBD. And this will also include some information about pain and fatigue, topics that were also covered in the Congress. So having IBD means that on the outside, sometimes things can look a little bit different than what's actually going on the inside. Many times, patients will spend hours just to get themselves ready to maybe come to an event like this, or maybe even just go pick their kids up from school. And on the outside, a patient can look, quote unquote, healthy, but on the inside they can be battling fatigue and stress and depression, anxiety, pain. Maybe they're not eating very well because they're not feeling well, or maybe they spent hours in the bathroom before being able to meet their commitment. So I think it's very important that we highlight the importance of addressing Crohn's and colitis from a multidisciplinary perspective in order to address many of the things that are happening under the surface. Some of these things can be experimental medications, like Dr. Scott talked about. As a psychologist, it's no wonder that some of our patients experience anxiety and depression, because those things come with the unknowns. Hospital stays, steroids, chronic pain, fatigue, relationship issues. A big topic is also, the finances that come along with having a chronic illness, as well as ostomy and the complexities of managing an ostomy, and then just the fear of future. Many of these things can be complex. They can be things that arise at different stages of life. And then they can also be things that we're thinking about as our disease and our life really unfolds before our eyes. So it's very important to recognize that for patients, we need a team that can help manage the things that are happening below the surface. So maybe as a patient you've heard your disease is in remission, and that's great news. That's really something that we want to hear. But you may also still be having pain or diarrhea or constipation symptoms, and at that point, at times, it can be you may be made to feel that your symptoms are in your head. And as a GI psychologist, I like to address this with patients, because certainly our symptoms can be driven by our brain that is connected to our gut, but it's not that your symptoms are being made up or are not real. And some of the effects of stress, as we think about those things underneath the surface that can bring about stress, is that stress really impacts patients that have chronic illness. From the perspective of neurons and the pathway that is lining our intestinal tract that runs right from our brain to gut, those effects of stress through hormones and chemicals can actually cause changes on our gut. So stress hormones can alter our gastrointestinal motility, which can mean it can slow things down or it can speed things up. It can cause changes in our visceral perception, meaning that the pain that we feel might not come up on a workup from your medical perspective. It might not come up on a negative lab, but that the pain is driven by the communication pathway happening between your brain and your gut. So that pain is real, but it's happening at the level of your nerves that drives that pain. We also see changes in gastrointestinal secretions and increases in intestinal permeability. All of this, down to the way in which our microbiome is impacted, can lead to symptoms and disease activity with inflammatory bowel disease. It can drive diagnoses such as IBS. It can also impact the way food affects our body and allergies, as well as upper GI symptoms such as GERD and heartburn. So I think it's so important when we're having those symptoms, but yet we maybe have a negative medical workup, that we talk with our doctors about what's going on in our lives. Also, I think it's important to recognize that stress can be acute and it can also be chronic. And sometimes patients will say to me, I've been enduring stress for a long time and I've been fine. And that can be that cumulative effect of that stress that finally your body just says enough is enough, and you may begin to experience symptoms. Other times, the acute effects of stress can be very present with you in the moment as you notice that you're experiencing stress, such as maybe you're at the grocery store and the first thing you look out for is where's the nearest bathroom. And as you walk in, until you find that restroom sign, your heart rate might increase and your breathing might get a little short and shallow, especially if you've had some discomfort in the abdominal region, or maybe you've been symptomatic that morning. So this is a visual experience of what we call the GI stress cycle. And in the teal circle there, the initial GI discomfort, this is where our symptoms can keep us a little bit on edge. It can make us aware of our body responses, and this can be experienced through what we call visceral hypersensitivity. So it's those nerve endings that are communicating, almost if you think about it in a way that's very loud, that communication pathway between the brain and the gut is too loud. We're feeling it too intensely. And some of these symptoms that are happening in the gut may just be related to normal gut digestive processes, but those nerve endings drive that pain. So that initial GI discomfort can sometimes lead to a cognitive response. Oh gosh, here we go again. Or, oh my gosh, it would be the worst thing if I'm in the grocery store and I can't make it to that bathroom. And as we have those unhelpful thoughts, it then revs the emotional experience. We feel more anxious. We feel more stressed. Maybe we almost feel angry because going to the grocery store really shouldn't be a stressor. We use that should language, and we set unrealistic expectations for ourselves. When we have these emotional and cognitive responses working together, it then leads to a sympathetic arousal. And this is your body's fight, flight, or freeze response. So in patients that have digestive diseases and disorders, this sympathetic arousal can include increased heart rate. Your breathing gets shorter and shallower. And when that happens, naturally the muscles in the digestive system begin to clench and tense and spasm, which is not going to help our GI symptoms any. It typically will then lead to a worsening of symptoms. So when I show this cycle to my patients, almost right away I start to get this nodding agreement of how did you get this experience that I go through so frequently written down on paper? This is me. And when I see that connection with this GI stress cycle, it can validate that experience for patients because you learn that you're not alone. You learn that this is a common experience for people. And I also can then begin to instill some hope for you that we can learn different strategies in behavioral therapy to start to break up this cycle, to address our responses to those unhelpful thought patterns, to learn different relaxation strategies to calm down that sympathetic arousal. And one of the things that I've shared here with you today is a link to diaphragmatic breathing. This strategy is not a magic pill, or it's not going to be like a magic wand to fix everything, but every single one of you out there that's watching this can benefit from having this strategy in your back pocket. It's something that even myself can utilize in any times of stress. So in learning how to activate your body's relaxation response, which is the counterpart to that sympathetic arousal that happens in times of stress, you begin to take control of calming down our stress response. So I would encourage you to check out that link, and there are certainly a lot of different strategies to learn breathing and relaxation interventions, but this is one way that you can begin to kind of decrease our stress response. Throughout the Congress, it was extremely exciting for me to see several GI psychologists as well as dietitians participating on panels. Something that's really fun and unique about the Congress is presentations about cases and learning about how different subspecialty providers would address that patient. And from a psychosocial perspective, we've really acknowledged that abnormalities can be related to this mind-gut connection. And while we see this most strongly in patients with irritable bowel syndrome, which is known as a disorder of gut-brain interaction, we also have to recognize it in inflammatory bowel disease. And recommendations are that we make a concerted and a collaborative, concurrent treatment for addressing the mind and the gut, as it can be so important in the healing that a patient experiences from their physiological symptoms. Additionally, nutrition is certainly something that I'm going to talk about in just a little bit, but certainly plays a role in multidisciplinary care and our quality of life. Yesterday, there was a phenomenal talk talking about a medical home and how we manage IBD. And this is not an exhaustive list of what your multidisciplinary team can look like. It certainly should include a gastroenterologist and a primary care physician with you in the center. You are the one that advocates the best for your health, but you want to use your team to make the most informed decisions and to feel as though you have the right team in place for those shared decision making experiences about whatever it may be in terms of your health, including a dietitian, a psychologist, a pelvic floor physical therapist, a pain specialist. The list can really become quite exhaustive, but it can be so important. And all of this requires a significant amount of emotional resilience and self-management. And these are certain strategies that can be addressed with a psychologist because they can be adaptive. We can learn how to become more emotionally resilient. We can learn how to have better coping strategies. And also, we can strengthen how we engage with our community through social support. In 2019, there was a Cochrane review that looked at the role of diet in IBD, and this is certainly a hot topic. And what is very important to kind of recognize is that firm conclusions really were not drawn in terms of the role that diet can play. If diet works for you, then we want to utilize that and get your nutrition as healthy and stable as we can. But diet will not cure, at this point, IBD. As Dr. Frank said, though, we have a lot of really exciting research that's happening, and certainly it is on all of our radar, and there is a strong role for working with a dietitian. But diet is not going to be the only thing that we look at when it comes to multidisciplinary care for our IBD. We also want to be very careful, and one of the big takeaways that many of the dietitians that are expert in IBD talked about over the course of this past week is that diet has to be personalized. It's really an N of 1. And so trying to do this on your own is very difficult. And that is one thing that the literature does point to, is that following some of the diets that we can try for IBD really should be done under the care of a dietitian. Overly restrictive diets over the long term is not recommended. Some supplements are not recommended. Expensive food tests really do not have a strong evidence base, and we really have to be careful with the alternative therapies. So all of you that are out there, I'd like to think that you're good consumers of the information that is out there, and we have to be very careful. One thing when a patient comes to me with a very long list of supplements that they're taking that can oftentimes be very expensive is I ask, how is it working for you? If the answer is they're doing really well and they can afford to take those supplements and their physician says that it's safe for them, then they may continue with them. But if you're not feeling well and your supplements aren't working for you, oftentimes we're so willing to do whatever it takes to feel better. We're willing to spend a lot of money, and it's unnecessary. So diet and supplements are very much things that we want to personalize for you, but be very careful with, because ultimately they could cause harm. Working with a registered dietitian is what's most recommended. There are a lot of people out there that could be health coaches or say that they have a specialty in nutrition, but working with a registered dietitian who has had an extensive amount of experience working with people with chronic illness is very important. Exercise is another one of those ways in which patients can really take control of their health and feel empowered. Exercise can spark endorphins and increase mood, and oftentimes it's not recommended for patients with inflammatory bowel disease. We do recommend that. If you are feeling well, you follow up with the same recommendations for any healthy control out there and get as much exercise as you feel comfortable doing. The important thing is to recognize, though, that you might have to make modifications. If you are somebody that has participated in a Take Steps challenge or has really made a commitment to both following through with your Crohn's and Colitis Foundation philanthropy through getting exercise, that's great. But you also have to be flexible and modify as it's needed for your health. So we don't want people pushing themselves too far. But gentle stretching, yoga, endurance training, strength training, those are all things that can really improve your emotional and physical health. And we just recommend that you talk with your physician about what your specific health plan should be. Fatigue was another great topic that we covered this week in the Congress, and certainly something that can be addressed from a multidisciplinary perspective. When it comes to fatigue, always report your symptoms to your physician. Sometimes there are different labs that they may want to run, such as looking at iron deficiency anemia, vitamin D, B12, and looking at your thyroid through the TSH. But also we can look at what's going on from a mood perspective with anxiety and depression, which can have a side effect of fatigue and sleep difficulty. Diet can play a role if you're experiencing malnourishment or skipping meals. That can impact your levels of fatigue. And finally, we can also work with sleep specialists to address sleep apnea if necessary, as well as sleep hygiene. So certainly making sure that fatigue is a symptom that you talk about with all of your providers. One of the highlights that I hope people walked away from in my psychosocial talk yesterday at the Congress was that emotional health is just as important as physical health. And we also have to address diet and nutrition. So we want to talk openly with all of our providers at each of our visits about our emotional, our physical, as well as our dietary and nutrition health. This is a wonderful resource that I'll just draw you to. Looking now for a GI psychologist in your area, we do have the Rome Foundation directory. And this is a growing directory, so if you go there and you don't find that there's a GI mental health provider in your area yet, we hope that that will be coming in the coming years. But using Psychology Today with these specific bullet points can help you to locate a mental health provider that can help guide you through addressing your quality of life and psychosocial needs, as well as stabilizing your mental health. We've also worked very hard at the Crohn's and Colitis Foundation to improve our behavioral and mental health resources. So this is a link to some of our fact sheets, different videos that are available to learn more about the role of stress, as well as what it might be like to work with a psychologist. We answer many of those questions there. And there are also resources for our pediatric patients that we encourage you to check out, such as Just Like Me and Campus Connections. Another resource for social support for our college students are various student organizations of patients that are coming together, students that are coming together and forming support networks right there on their campus, wherever they might be located. So a couple key takeaways are that fatigue is very common and can be driven by many factors such as depression, anxiety, sleep, diet, and physical activity. So we want to make sure that you're addressing all of those factors with your provider by talking about your fatigue and what might be contributing. Individuals with stable disease are not restricted from physical activity, and we encourage you to find what you enjoy doing. Malnutrition is an under-addressed symptom and issue in patients with IBD, and routinely we want to share weight fluctuations with our providers as well as what our diet is that we're following. And quality of life can improve when these issues are addressed with the correct multidisciplinary team. These are just a couple takeaways of things that you can discuss with your healthcare team that we recommend you review. And additionally, some final resources that will be available to you after our IBD Insider program. Now we're going to take a couple questions.
Thank you, Dr. Reel. I really loved your presentation. My name is Amber Tresca of About IBD and IBD Moms. I especially liked, Dr. Reel, your slide with the iceberg. I feel seen, that there are so many things that are under the surface that we need to address, and sometimes we end up addressing them sort of by ourselves, but there are so many ways that we can loop in our care team and maybe find new members of a care team. So the first thing I want to ask you is about finding a mental health care professional. I think that's a giant hurdle for a lot of patients. So what should patients be looking for when they first start trying to find someone to address their mental health?
It's a great question, Amber, because being a behavioral psychologist and working with patients that have IBD, it looks a little bit different than how we might traditionally think about mental health treatment. Mm-hmm. Treatment might be short-term. Mm-hmm. And you might have very specific things that you want to work on when it comes to working with your psychologist, such mm-hmm. as learning coping strategies or addressing shared decision making, or maybe you're experiencing symptoms of anxiety and depression that are related to your disease, mm-hmm. not necessarily related to outside factors in your life. So looking for a mental health provider that utilizes cognitive behavioral therapy, CBT, which is an evidence-based intervention oftentimes used in healthcare settings, is important. Talking with a mental health provider. So I gave some resources on kind of how to locate somebody. Mm-hmm. But don't be afraid to ask questions when you call them up to say, mm-hmm. have you ever worked with somebody with inflammatory bowel disease? These are my goals. Do you think that aligns with what you might be able to help me with? Mm-hmm. And if they give you an answer that feels comfortable, then give that a shot. Mm-hmm. If it doesn't, though, if you don't feel comfortable, if you don't feel like you're being heard, mm-hmm. there are lots of us out there, and you might just have to find a different fit. But certainly somebody that specializes in CBT, that is comfortable managing anxiety, depression, mm-hmm. Relaxation-based training, stress management, those are all things to ask about.
Mm-hmm. Those are great tips. So I want to dig into a little bit more about the cognitive behavioral therapy and CBT. That kind of may give a visceral response in some people. That what does that mean? And how long does it take? And what kind of results maybe could you expect out of that?
Yeah, so CBT is essentially it's learning strategies to recognize, one, how we think. So our brain thinks, that's what a brain does, and oftentimes, we're thinking about the future, and that can be anxiety provoking. Or we're thinking about things that have already happened, and that can be where depression can kind of live. We also have more information about patients with IBD having higher prevalence rates of trauma. And so working from this perspective of identifying how do those thoughts, how do those experiences impact how we feel, and learning strategies to observe that thinking and maybe make alterations in it or find ways to accept it. That's what CBT gives you strategies to address. So it's oftentimes a very present-focused type of therapy. We don't have to dig down deep into your history or your psyche to do very meaningful work. And patients like that. They like that it's present-focused. You oftentimes are walking out with tools and strategies that you'll implement the following week. And then when you come back to therapy, we're talking about how did that go? What did you learn? What was difficult for you? What are some of the emotions that are coming up? And so it tends to be a short-term therapy. So anywhere from, I've worked with patients for 1 or 2 sessions, up to maybe we do 7 sessions and then move to once monthly we check in. So there are different ways that we tailor the treatment plan for what works for you.
So is therapy forever, every week forever, every month forever, or are there times when you say, okay, maybe we can take a break for a little while and just call me if you have an issue again?
So yes and yes. Sometimes patients, based on where they're at in their life stage, they really could benefit from once weekly therapy for a while. And I think that good therapy tracks progress, right? So if you're making progress as a therapeutic relationship together, you would work with your therapist or psychologist to decide, you know what, I've been doing really well. I have a lot of tools and strategies. I don't think I need therapy as frequently. So you might then take a break. And sometimes I think about myself like an attorney on retainer, that you can kind of use me as you need me. And especially in inflammatory bowel disease, where we can have these ebbs and flows in health, you might not need me for a while. And 2 years down the road, I plan to be working for a while, so my door is always open. I get patients that kind of return back, and we might then work together for a few more sessions, and then you go on your way. So it can be very flexible.
Yeah, thank you. That's really very helpful. So I want to check in with Kat and see if we have any questions.
Yes, we have one question. If you recommend therapy for patients, what is better, group or private therapy?
So I think the benefits of group therapy are that you can be in a room with people that might not necessarily have the exact same things going on, but that you can feel validated and kind of share some common experiences or common feelings. We don't see this a ton. There's not a lot of availability for group therapy for various reasons, but we do have support groups that might not necessarily classically fit group therapy speak, but I think that support groups can be very helpful. But for a lot of patients, I think they benefit from some very individualized therapy. But give it all a try and see what feels best for you as well.
Another question has come in. Is it common to have PTSD related to severe complications? What can I do?
Yeah, so Dr. Tiffany Taft, who was here at the Congress, has done some recent research looking at post-traumatic stress in patients with inflammatory bowel disease. The rates are quite staggering. Close to 30% of patients meet criteria for this post-traumatic stress. So it is something that is being newly researched. It's likely that we're going to find these numbers are even higher as more and more research is kind of rolling out. So certainly medical-based trauma can lead to this diagnosis and should really be addressed with a clinical psychologist who specializes in health and trauma.
We have one last question. If stress is important, would anti-anxiety or antidepressant medications be useful?
It certainly can play a role. Again, I think starting with talking with your treatment team is important. So based on the severity of anxiety or depression, you may decide, let's start with therapy first and see how, when I learn strategies, when I stabilize mood, how am I doing? If you've been doing individual counseling for a while and your mood is not stabilizing the way we would like, or to get you feeling better, we then might recommend consultation with a psychiatrist to introduce a neuromodulator or an anti-anxiety or antidepressant medication in combination with your therapy. So the research shows us that, if you've given individual therapy a try for a little while and we're not finding that we have the right results, the best outcomes are in medication and therapy.
Thank you so much again for your presentation and for answering all these questions. And now we're going to go to the next presentation with Dr. Rubin.
Thank you, Amber.
Great job. Okay, well, welcome everybody. My name is David Rubin. I'm at the University of Chicago, and as you heard, I was the chair of the Crohn's and Colitis Congress here in Austin, Texas this year. The Congress is in its third year, and it's a collaboration between the Crohn's and Colitis Foundation and a professional organization that many of us belong to called the American Gastroenterological Association. And the Congress this year was the most successful we've had. There were over 1,400 people here, and it included a number of very important patient advocates. And when we had some of our case discussions where we were reviewing different patient stories, we included not just the gastroenterologist or a surgeon, but very importantly, a multidisciplinary team that was sitting in a panel like we're doing here that included our psychologists and dietitians and additional mental health professionals, and patients were on all of these panels. So it is natural that we wanted to take the great success of a professional meeting like the one we just finished here in Austin and share it with the patient community. I personally am very grateful to the Crohn's and Colitis Foundation and to the AGA that they saw some wisdom in this proposal and that they were so enthusiastic about bringing this program to you. We believe this is the first national IBD patient education program, and so we definitely want some feedback so that we can learn from this and try to do it again and improve in the future. My topic is research, and people talk about research all the time. We often are raising money for research and talking about doing more research to improve how we take care of people who live with these conditions, but actually we don't often explain what research really is. So I've put together this presentation for you to try and teach you the basics of research so that you understand a bit more about what we're trying to do. And of course, all the advances that you've already heard about from my colleagues today are based on research that has been performed or research questions that we have yet to answer. All right, let me move through. So what I'm going to do in the next 20 minutes or so is cover the importance of research to inflammatory bowel disease. I'll give you some very specific examples. I'll teach you how research is performed and how it is then presented, and I'll also update you on the great work that is being done both by the Crohn's and Colitis Foundation as well as by the American Gastroenterological Association. I'll do my best as well to just touch on the research highlights from this meeting. So what is research? I'm sure that many of you have your ideas of what that might mean, but an actual definition is a process of steps used to collect and analyze information to increase our understanding of a topic or issue. You may do research all the time in the form of an internet search to find out information about therapies or opportunities to treat your disease better. Research is usually performed with 3 steps. The first step is that you pose a question, something that you want to answer. The second is you collect data in order to answer that question. And very importantly, the third step is that you present the answer to the question, or you share it broadly so that it can be disseminated and expanded upon. There are many unanswered questions in IBD, and everyone who's logged in today knows that. There are a variety of different types of research. In fact, there are 4 main types of research: basic, translational, clinical, and outcomes. And the type of research we perform depends on the question that you're asking. If you're asking what is IBD from the standpoint of what it actually is doing in our bodies, there's some types of research we might perform. If we're asking what happens to our immune systems when we have inflammatory bowel disease, there are other questions and types of research we might perform. What's happening to our gut microbiome? Remember, the microbiome are all the organisms that live in or on our body, and the gut microbiome appears to play a critical role in some of what we're observing in IBD. What treatments work for IBD is obviously a very important question that leads to research. What does the environment contribute? What other medical problems might patients have that coexist with IBD? And what are complications related to the chronic nature of the disease or complications related to treatments? All of these questions pose interesting things that we can be considering for research. Now, the types of research I'm going to break down a little further so you understand them. Basic research is sometimes called bench research, referring to the laboratory bench. It aims to advance scientific theories for improved understanding or prediction of natural or other phenomena like disease processes. Examples might be cell cultures, where they grow cells in the lab, or DNA sequencing, or the analysis of the microbiome, or chemical reactions, and using animal models of inflammation to study IBD. Translational research is sometimes called bench to bedside, referring from going to the bench in the laboratory to the bedside of the patient. And this is research that leads to creation of new therapies, medical procedures, or diagnostics. And examples may be biopsies that are obtained when you have your standard endoscopy procedure, or using basic research to understand mechanisms and then try to determine whether that can be converted to a therapy for a patient. Clinical research is perhaps something you know the most about or have been exposed to. Sometimes this is also called patient-oriented research. One of my mentors always said that any research we do, whether it's basic, translational, or clinical, should be patient-oriented, and I happen to believe that. But this studies the safety and effectiveness of our medications, devices, diagnostic products, and treatments. And this can also include clinical trials for new therapies. So I want to make a point here that I'll make again, which is that every treatment that's currently available to treat Crohn's disease and ulcerative colitis had to go through a clinical trials process to get here. And in order to do that, it needed patients who were participating in those trials. In order for us to advance new therapies and develop new ways to do things, we need more patients to be participants. So I'm hopeful that at the end of my presentation, you will be considering whether you can participate in upcoming research for IBD. Outcomes research is the fourth type of research, and this can be part of public health research. This might look at large populations of patients in aggregate or do epidemiologic studies to understand what's happening at a population level. And this can lead to an improvement in understanding what's going on in terms of trends of disease or delivering services to large populations. Now, when we collect the data, there are different levels of evidence, going from the weakest at the top of this slide to the strongest at the bottom. The weakest level of evidence is just the opinion of experts, people who say, I'm experienced and I want to tell you what I think. That may have some value, and some of what we do in clinical medicine, in fact, is based on the opinion of experts. But it's not scientifically rigid, or certainly not enough to give us the data we need to make major changes. The second level would be cases reported. I saw a patient with X and we did Y. This is a common way to report what we're observing that can lead to hypotheses of other ways to study and improve care, but it doesn't necessarily lend itself to strong evidence. More importantly are when we do randomized trials, where patients are randomized to different arms or different treatment strategies or different interventions, and we might be blinded. Blinding means that we don't know what treatment they're going to receive, and the patient may not know what they're receiving. And those trials are thought to be stronger because the results are not biased by our pre-test hypotheses or by us knowing something and expecting a certain result. And then there are multiple randomized trials, which is an even higher level, meaning that after we finished one randomized trial, we did multiple others with different populations and had the same results or different results. And when we combine them all, we can assume that we're making great progress. The level of evidence is very important to understand, especially if you're doing your own research on the internet. If somebody is claiming something on the internet about a treatment that they would like to sell or a diet that they're recommending, you'd like to know, how is this studied? Is this just the opinion of somebody? Is this just a single case or some people who are describing their story? Or has this been studied in more rigorous ways? Now, for clinical trials that lead to therapies that come to market, there are different phases. I'm going to briefly mention what these are. The first phase is when they have a drug that seems like it's promising, but they want to study toxicity. This has to do with side effects and how much of the drug in a patient causes certain effects related to safety primarily. Once they've determined how the drug behaves and is metabolized in humans, and often it's healthy people who do phase 1, Phase 2 involves dose ranging and looks at some effectiveness as well as ongoing interest in safety. These are a bit larger than the initial phase 1, but they're still often smaller trials. But this does include people who have the diseases of interest. Phase 3 is the major phase that leads to drugs getting to market if they are successful. The FDA usually requires at least 2 identically designed phase 3 trials in order to have a drug tested against either a standard of care therapy or placebo to demonstrate its benefit and its safety before it can come to market. After the drug is approved and becomes available to all of us, there are also phase 4 trials, which are sometimes called post-marketing, and these are sometimes done to look at greater safety over time or to look at other effects of the therapy once it's on the market. It's very important to look at phase 4 so that we continue to be vigilant about any potential safety concerns of new therapies. So one of the other areas that you might want to know more about is that if you're going on a therapy that's in clinical trials, which phase is it, and whether or not you'd be receiving one arm or another. Why do placebo-controlled trials matter? Well, because sometimes we have a therapy that we think for sure will work, but in fact we end up seeing a placebo response that is almost as good or better than the trial drug that we were exploring. In this particular slide, I'm showing you a drug called etanercept, which is like one of our TNF blocking medicines you heard about from Dr. Scott. But etanercept works in rheumatoid arthritis, and they assumed it would work in Crohn's disease. If you look here, you can see placebo are the bars that are with diagonal lines on them, and it actually didn't do as well as placebo in some patients with Crohn's. So even though we thought this drug should work because drugs like infliximab and adalimumab seem to work so well in Crohn's disease, this particular product did not do better than placebo. If you hadn't compared it to placebo, you might have thought it was a very good drug, and it would have come to market and not been much better than doing a placebo intervention. So it is actually important that we understand this. But placebo is not for everyone, and placebo shouldn't be included in every trial. In fact, placebo has a role when there's no established standard of care, meaning we don't know what the best treatment might be at all. Placebo can have a role if there's something called clinical equipoise in the trial design. What that means is that there's an equal likelihood in the investigator's mind, the doctor's mind, that you're going to respond to either arm of the trial, whether it's placebo or drug, or one dose of the drug or another dose of the drug. Clinical equipoise is an ethical principle that means that it's thought by the investigator that it's reasonable for you to be in either arm without harm. If you were going into a trial where we automatically assumed placebo was going to be worse or might cause harm, that's not ethically designed, and it shouldn't have a placebo arm. So I want to reassure you, and certainly you should learn and ask questions, that placebo-controlled trials, when they reach the level of the FDA, are thought to have equipoise and therefore are thought to be ethically justifiable. And therefore you should also recognize that if you were randomized to placebo, the study design is supposed to address any concerns you may have about that. I want you to think a bit more about that. So how do we do clinical research? As I told you, we start with a question, then we develop a hypothesis, which you may remember from earlier in your education. Then we develop methods to test our hypothesis, and those methods vary widely. We determine the number of experiments or the number of patients we need in order to have significant power. The term power means that we have enough experiments or enough people so that the result is not likely to be due to chance. It means that if there's a difference in our result, it has statistically significant relevance, and therefore the result is powerful enough to be meaningful. How does this translate? If you hear about something that had 21 patients in it and there was some benefit, but it didn't show statistical significance, that means that it probably was underpowered, or that there may not be a statistical difference between the treatments. So you have to be careful to understand, was this powered enough to actually show a real difference so that we can trust the results? We obtain ethics approval, which is sometimes called Institutional Review Board or IRB approval. The study is then performed, the results are analyzed, we report the results, we publish the results, and then we go on to our next hypothesis and we start over. Very importantly and relevant to this meeting, because we had a lot of research presented here, is that it can be the best science ever, but if you don't share it with the world, it doesn't matter. So I said, if a tree falls in a forest and there's no one there, did you hear it, or is it make a sound? So the different formats for presenting research is very critical, and there are different levels of doing this. Abstracts are submitted to conferences like this one, like the Crohn's and Colitis Congress. They're reviewed by other experts, and the abstracts that are judged to be meritorious are then allowed to be presented in different forms. Posters, as you can see in some of these pictures, are summaries of all the work, and then the investigator stands by the poster and describes them to people who come by during a scheduled poster session. A higher level of presentation is an oral presentation where you're invited to tell your story orally to an audience at a podium, as you can see in the other pictures here. But ultimately, as much as we enjoy presenting in front of our colleagues and getting feedback, we try then to publish it in a journal, journals that are peer-reviewed, reviewed by other experts. So a publication that has met the standard of peer review, it's gone through expert review, and is deemed appropriate to be published in a scientific journal, has reached the level of acceptance in the scientific community and can advance our field. Very important. And of course, these days, there's other dissemination of all this by Twitter and Facebook and podcasts. There are a number of journals that the Crohn's and Colitis Foundation has that I've highlighted here on the left. The IBD journal, this comes out monthly for the members of the foundation, and also online. And they also have a new online journal called Crohn's and Colitis 360, which is actually very much focused on all the multidisciplinary aspects of IBD. The AGA has a number of journals as well. In fact, the #1 journal in our field in gastroenterology is the journal called Gastroenterology. But they also have a clinical journal called Clinical Gastroenterology and a translational journal called the Cellular Molecular Gastroenterology and Hepatology Journal. So all of our societies try to support the research we do in a variety of ways, one of which is to have peer-reviewed journals. And of course, there are hundreds of different journals. Now, getting to what the Crohn's and Colitis Foundation does, and if you're wondering, how are we going to make progress in IBD, which I wonder all the time, you can look to what the Crohn's and Colitis Foundation has done to issue, and they do this every few years, a roadmap to future research. It's called the Challenges document. They bring together all of their different experts who volunteer for the Crohn's and Colitis Foundation. These are physicians and scientists and patients, and they come up with a number of priorities to lay out what we think are the most pressing issues and some of the strategies we might use to advance the field. The recent Challenges document was just published in 2019, and it had a number of significant different sections. Preclinical human IBD mechanisms. Preclinical refers to animal models or laboratory work in the bench. Environmental triggers, what's going on in the environment that might be turning on IBD, and explain why it's rising in all parts of the world. Novel technologies, what are the new technologies that might actually advance our field or our ability to take care of patients? Precision medicine, this has to do with what you heard from Dr. Scott about, which relates to How do we dose therapies? How do we choose therapies that are individualized, recognizing that people's IBD is individualized? And pragmatic clinical research, this was an area that I worked in, that has to do with how do we design better clinical trials, how do we create databases and biobanks that we can get meaningful information from, and how can we really move the field forward by using all of our resources to take better care of our patients. And what's on this slide and on your screens at home is a QR code. If you have a modern smartphone, if you point it to it with your camera, it'll take you right to that website, but the link is there on the slide as well. Now, of these different priorities, I want to also tell you that the Crohn's and Colitis Foundation is the #1 funder of significant research that is focused primarily on IBD, with over $375 million invested since the organization got its start. That is really remarkable, and I think they're using their money wisely, and we know that the majority of money raised goes directly to the research and to the care and advocacy and education of the people who need it, which is all of you. And so if you haven't joined the foundation, this is also my plug to make sure that you take a moment and join this amazing organization. The AGA is also very involved in research, and unlike the Crohn's and Colitis Foundation, which is focused on inflammatory bowel diseases, the American Gastroenterological Association covers all of the GI hepatology world, so that's the digestive tract, and so they're much broader and much bigger. But they do have a couple areas that I thought to highlight for you related to IBD. One is a national fecal microbiota transplantation registry. This is a registry to track the outcomes of everyone who's getting fecal transplants, mostly for an infection called C. diff that Dr. Scott mentioned, but also in clinical trials where we're trying to figure out whether this might be a treatment for IBD. And the American Gastro Association also provides research grants to scientists that are abroad and often end up funding IBD research. Now, what are the major advances that we've done? There are many, and every new treatment, as I mentioned to you, came to market because there were clinical trials and clinical research, and before that, translational research or even basic research that led to those new treatments. Like the newest treatments for Crohn's and colitis, ustekinumab, or the treatment for ulcerative colitis, tofacitinib, and some of the new work that's coming out related to partial enteral nutrition or exclusion diets for children with Crohn's disease, as well as some additional work going on related to microbiota treatment, or at least exploring that in ulcerative colitis. Other research, new approaches to diagnosis, like how can we use stool markers to gauge and measure inflammation instead of scoping people as often, and that has now made its way into guidelines. And how can we use better technologies in the endoscopy suite, high-definition scopes, to see and prevent early-stage cancer or precancer. And then also, of course, how do we prevent our therapies from losing response, and how do we make them work better? And a variety of different research related to checking drug levels and understanding how to pick the right therapies for our patients. At the Crohn's and Colitis Congress just this morning, we had the keynote speaker, who was a guest of ours from the NIH, the director of the National Center for Complementary and Integrative Health. This woman, Dr. Helene Langevin, gave us a beautiful lecture talking about how complementary health and integrative health can be combined with some of our conventional approaches, not separate, not to the exclusion of them, but combined with them in ways to better understand how we can treat our patients. She gave us some very enlightening work, and I would encourage you to go to the Twitter feeds from her lecture to see a little bit more about that. And I'll just conclude by saying there was a lot of research at this meeting. In fact, we had an increase over last year. There were 192 different abstracts presented at this meeting. Most of them were in poster form, but we also heard from 28 authors who were allowed to do oral presentations. So we're always trying to do this better and to learn from our colleagues and to advance the science of inflammatory bowel disease. So the next time you see your healthcare team, whether it's your physician or your advanced practice nurse or all the other people that are involved in the care of your IBD, I think it would be reasonable and important for you to ask about research. Are you involved in research in your practice? Community practices are involved in research as well. Are there any clinical trials I might be eligible for with new therapies that offer different mechanisms or perhaps a better safety profile? I think it's really important that our patient community starts guiding us as to how we can get them more engaged, because without that, we're not going to be able to make progress. And we have so many promising new therapies that are waiting for us to finish the trials. And the rate of recruitment in the United States right now, you're not going to believe the statistic, is about 0.1 patient per center per month. In other words, 10 months to get one patient from a center recruited into a clinical trial that may need hundreds of patients to be completed. So we really need to figure this out and to get more people involved. And one of the ways is what I'm doing here, trying to educate you about how this all works. There are some resources in your slides that you can see here, both from the AGA and from the Crohn's and Colitis Foundation, and you can certainly check them out, including a clinical trials community, which will tell you more about what is available to you and where you can go if it's not in your current doctor's office. So with that, I want to thank everyone for being part of this novel and innovative and inaugural program, and I look forward to some questions and talking to my friend Tina, and then, of course, hearing from all of you. Thank you.
Thank you so much, Dr. Rubin, for your enlightening presentation on the research that went on at Crohn's and Colitis Congress this year. My name is Tina Swani Omprakash. I have a blog and social media advocacy platforms called Own Your Crohn's. And Dr. Rubin, I wanted to sort of sit down and talk to you a little bit more about clinical research. The reason why is because over the years as an IBD patient, I've had Crohn's myself for 14 years. One of the things that I had a lot of trouble wrapping my head around was clinical trials. And I know you went into quite a bit of detail on clinical trials, but I think there's a lot of questions on my mind, even on the minds of other patients, about how clinical trials sort of work. So with that, I wanted to ask you, why do you think clinical trials are so integral to our care, and why should we be looking at them and considering them when we have a wide variety now of treatment options that Dr. Scott went over?
Thank you, Tina. And this is a very important question, so I appreciate you bringing it up. The reality is that while I do firmly believe we've made tremendous progress in our ability to treat inflammatory bowel disease, even in my career, which is hopefully going to continue for a long time as well, I've seen tremendous changes. In fact, I often tell patients that every 2 years we have a paradigm shift in the way we think about managing IBD. But that has to happen with the investment of everyone in recognizing that although we made progress, we're not where we need to be. And I happen to be a perfectionist in some ways, and that's a good thing if your doctor's a perfectionist. But that means that I don't accept less than figuring out what's going on. And of course, we want to cure these diseases. So participation in clinical trials, whether it's for novel therapies, new targets, and new drugs, or clinical trials related to other interventions, like dietary interventions. The Foundation, in conjunction with the NIH, just finished the first randomized trial of 2 different dietary strategies in Crohn's disease. We're waiting for the results, but it's a very important trial in that regard. And it took people to be interested to participate. Mm-hmm. One of the misconceptions about clinical trials and a hesitation is that the patient is exposing themselves to risks that we don't know anything about. And so when you heard today about different phases of clinical trials, it should be in some ways reassuring to individuals to know that before a trial reaches the level of humans, a lot of work happens in animal models, and there are different phases of the trial before it gets to a phase 3. In addition, people often don't know that at any point in a clinical trial, you can withdraw. You're not bound in any way to stay in the trial. That is part of patient autonomy in clinical trials. And many of the trials are designed, if they have a placebo arm, or if they have a lower dose arm, or some arm of the trial that the patient may receive, and they may be blinded to what they're actually receiving, that the trial automatically lets them go into a higher dose arm or even what's called open label, which means then the patient knows they're actually getting drug. So we may say you're going to be in a placebo-controlled component of the trial for the first 8 weeks, but then after that, if you haven't responded adequately, you're going to move into the open label and get the new drug. So there's a lot of pieces to this that I think require people to ask the right questions like you are and to learn more before they reject it whole hand. And there certainly is a lot of room for improvement in what we do in IBD management. The last comment I'll make is that when we wait for patients to fail every other treatment on the market before they consider themselves for a trial, we've often waited too long. The trials are often exclude people who've failed everything because those are the hardest patients to treat. And for the patient who've tried all sorts of different things, including non-traditional treatment strategies, their disease may have progressed and they may be suffering a complication by waiting too long. So I really want to advocate for people to learn more and become informed consumers of the clinical trial process.
Thank you so much for going into that, Dr. Rubin, and clarifying about clinical trials. The next question I had was, can you elucidate a little bit more on what the clinical trial recruitment process looks like? Who usually qualifies? I know that you mentioned that it's usually mild to moderate types of disease, but who usually qualifies, and who's a good candidate, and why might be a better candidate?
So first of all, for patients who are considering their treatment options, one of the things they should also be asking and thinking about is there something newer that might be better that I could get now or learn about? You can start by asking your physician, but I would actually encourage people to go to the NIH-sponsored website called clinicaltrials.gov, clinicaltrials, plural, .gov, where they list all the clinical trials have to be registered there of any kind. And the clinicaltrials.gov site, you can search it. So you type in Crohn's disease, and you'll find all the different trials going on in Crohn's. Now, you may not be eligible for all of them. They sometimes list the eligibility criteria, and sometimes you may not understand some of those criteria. But they also will tell you where the studies are occurring, because most of the trials require multiple sites, over 100 sites, to participate in order to get enough patients, as you heard me say. So the way to learn more about what trials are available and whether you would qualify is to ask questions and look into some of this. And you might be surprised to learn what's available to you and what's around the corner that might be very interesting and important for you personally. And then there's, of course, the altruistic element of it. Everyone who participates in research is helping the rest of the world who lives with these diseases advance our field as well. And I recognize that first and foremost we want you and your loved ones to be well, but it certainly helps to be contributing to the rest of what we're trying to do.
That's a great point. I think clinical trials are really the hope for our future as IBD patients, so I'm glad you brought that up. I had one question before I wanted to check in with Kat to see if we have any questions from the live audience. I know you mentioned the placebo arm. Now, can you tell us a little bit more about what a placebo is and which phases it might apply to?
The placebo response is a well-described phenomenon, and it is fascinating. So in general, placebo is something that is inert. Often it's sugar water or it's a capsule that doesn't have anything in it, but it's designed to look like the treatment that the patient's receiving that's active. And it is designed as well to test whether or not the treatment that the patient's receiving has a benefit over getting this other arm. People's mistake is to call placebo nothing. I don't want to be randomized to get nothing, because a fascinating thing that has been described in all the trials in Crohn's and colitis is that patients who get placebo, some of them respond. This is why there's clinical equipoise for placebo. Not always in every trial, but for many of the trials, if they have a placebo arm, the reality is that some people respond to this. Now, why is that? Well, for a while it was thought that it had to do with the fact that when you're in a trial, you get a lot of the care for free, and you get more intensive care, and you get more attention from the team, and you're more likely to take your existing medicines that you're staying on. There's all these other elements that might confound how you would respond to it. The other part was, well, it's all in your head. Well, we've learned that that's really not the way to describe this at all. But we have learned that there's a very powerful brain-gut relationship and brain inflammation relationship. So if you believe you're in something active that may help you, it can actually improve how you do. It is a remarkable observation that I have personally witnessed many times. And the last thing I'll say is that we've learned that actually people receiving placebo actually have a biochemical response. And what triggers that and how that works, we don't know. So it's not always an automatic bad thing to be in placebo. In fact, some of our newer trials have demonstrated that the drug was safer than the placebo because you treat the disease and you don't have the side effects and complications of the disease. And the placebo patients may have progression of their disease or other things, and so they don't do quite as well. So there's a lot of pieces to this that I think are worth hearing. What people shouldn't think, and I want to make sure this is clear, is that they're just being a guinea pig. Nobody's testing them unnecessarily or willy-nilly or doing things that are not closely regulated or designed properly. And I'll guarantee you that people like me and Dr. Scott are in the room with the industry folks who come to us and ask for opinions. We're not going to let our patients, whom we love and care about, get into trials where they're going to be harmed. We won't. We stand up for them and we design these things to be better. And so please ask more about this.
Thank you so much for going into that and for standing up for us and voicing our concerns. With that, I want to turn to Kat and see what questions might be coming from the live audience.
We have one question from Cheryl, and her question is, what is the minimum length of time required for a drug trial to determine potential side effects before the drug is approved by the FDA?
Thank you. It's a great question, Cheryl. It varies a bit, but in general, the trials are powered for time, number of patients, and number of people who actually receive the active drug to know this. But in general, we say, including the phase 2 parts of trials, and then phase 3, over a year, and often it goes back more than 10 years in the design of a lot of these drugs. And sometimes new therapies are extrapolated from therapies we already have. They're just improvements on them, so we can learn from that as well. So I understand the concern that tomorrow the new drug is going to have a side effect nobody knew about. So those are important questions we always ask about. But the FDA was designed initially just to look at safety. That's its main focus. Then it talks about effectiveness, and it's very concerned about that for all of our well-being. Okay, so I'm going to moderate a few other questions from the rest of the virtual world, and maybe I'll stay in my seat and we'll call upon our wonderful panel so you can all participate. Hopefully your wireless mics are working there. So Kat, do you want to help us out? And I'd like to give a shout out to Dr. Jamie Kanukin from the University of Michigan, who's been screening our questions and helping us in the background today. So thanks, Jamie.
Along the lines of research, can patients in remission still participate in clinical trials?
There are many clinical trials looking at maintenance therapies or withdrawal of treatments or other outcomes of interest. Remember, clinical trials are not always about new drugs. Sometimes they're about outcomes related to your general health and well-being and your other components of your life. So you should still be interested and look into what's going on. We have a number of trials right now, by the way, that are systematically and carefully withdrawing treatments and watching how patients do after that happens. So the answer is absolutely yes.
Another question, can you be vaccinated against shingles while on certain medications?
I'll let Dr. Scott take that one.
Up until, I guess, 18 months ago or so, the answer to that would have been probably not, because Zostavax, which was the shingles vaccine that was available, is what we refer to as a live attenuated vaccine. And it's important that patients with IBD that are receiving our immunosuppressive medications recognize that they should never have live attenuated vaccines. However, there is a new vaccine for shingles called Shingrix, which is a dead vaccine. And this is thought to be safe and effective in patients with inflammatory bowel disease receiving immunosuppressive medications. So they can receive that vaccine.
Yeah, and I want to emphasize people should get vaccinated. Vaccines work, vaccines save lives, and you want everyone vaccinated because if you're on other therapies, you want the world around you to be protected too.
We have a question from Mark asking, are there any therapies that are possibly more effective at reducing stricter complications in Crohn's?
Go ahead.
Right now, all of our available armamentarium targets the inflammatory process. So if there's an inflammatory component to strictures, The medication potentially can reduce the inflammation and open that area up. What we are lacking right now, the large knowledge gap, is therapies that might actually reduce the fibrotic process. And that's an area of active research. There's a number of my colleagues that were present here at the Congress that are very invested in trying to figure that out, but it's a work in progress right now.
It brings up a very important message for everyone, which is that living with active disease, when we have effective therapies that may be working for the patient, can lead to progression of the disease. And we have very good results with many of our treatments to turn off the inflammation, and in general, as Dr. Scott said, turning off the inflammation can prevent progression to scar tissue. We don't have a treatment that's anti-scar yet. We're working on it. So in the meantime, the point here is if you feel okay but aren't quite where you need to be or know you have active inflammation, it's important to have a conversation about what are the other treatment options before you get to progression and try to prevent those things. We know in many studies that the earlier a patient gets treated in their disease course, the more likely they are to respond, the less likely they are to lose response to therapy. So we want to empower patients to understand this message, that it's not just about symptom management, which is directly related to your quality of life. We want you to feel better. We also want to document and confirm that the inflammation is controlled whenever possible.
Great, thank you. One question we have is related to diet. Can you comment on what we know so far about the role of diet in IBD?
Well, as moderator, I'm actually going to ask our expert patients to comment on what they, because this is a very informed group. Why don't you share with us what you've learned or what you've incorporated or what advice you might give other patients regarding diet, and then we can discuss some other things. So who wants to kick it off? Amber?
So what I've heard over and over again in coming to Congress and to other events is that a lot of the experts are recommending a Mediterranean diet, which, like, I don't even know what that means. So, and I would love to learn because I love food, and I know that the first response that a lot of patients have is that I think that's a lot of fiber, and how can I do that? And I think the answer to that is, but that should be your goal. Your goal should be to getting to where that you can eat fiber and you can eat the way that's going to be most helpful for you, and that, you know, it might be that Mediterranean diet. But how about you guys? What do you think?
I mean, I think that all the time, some of the initial stuff that we even hear as patients is related to diet. I think that there's a lot of great research going on for diet, and like we're getting to a point to where we can kind of see what exactly is working and not working. But it's tough. So, I mean, it's hard to realize that it's not, you know, it's not specific to a lot of people. Even us three up here can all eat different things that may make our symptoms worse. You know, and I think it's something that you just kind of have to explore for yourself, and then meet with a dietitian, you know. But that's a huge question that we get all the time. You know, how does diet affect it? And it just varies so much. So it's extremely important to meet with a dietitian as well. But also realizing that you need more often just need other therapy, so making sure that you're working with your physician, you know, and a dietitian, and kind of going from there to see what works best for you, but also making sure that you're still getting your inflammation controlled.
So although we think it may be that diet has modified the microbiome or is exposing our immune systems to certain things that we don't quite understand yet and causing these diseases, we haven't made the progress necessary to know about what diets will truly do what we need to do here. That doesn't mean that we can't try certain things, and I absolutely agree that it's individualized for patients. But one of my messages always is that if you find that despite removing certain things from your diet, you continue to have problems, it's less likely what you're eating and more likely your bowel that's driving all that. So while I do endorse a Mediterranean-style diet for many people, which is fish and olive oil and some green vegetables and healthy nuts, we haven't proven that that's actually better than anything else, but it seems reasonable. Less processed foods and some other recommendations. We're working on this, but what we've learned is just like everything else, it's individualized. Your body responds differently to different components of nutrients. The way it affects your microbiome may be different. Where you were born and how you acquired your microbiome from your mother may be different. So patients who were born in other parts of the world and then came to the United States, that might be part of this. So it's a very individualized, complex problem. I would actually recommend that we work more closely with our very well-informed expert dietitians and that we continue doing the research we're doing. What we do know is that people who try gluten-free or dairy-free often feel better, but it hasn't been shown that it controls your inflammation. So don't get confused. We want you to feel better, and that's fine, but you want to make sure the disease is also being monitored and controlled properly.
One more thing I just want to add,
Absolutely,
Dr. Rubin.
Megan. Thank you.
Food fears are something that are really common in our patients as well. So making sure to address this as it relates to your diet. Maybe when you were flaring, you developed sensitivities to certain foods that then, as you're feeling better, more anxiety can kind of creep up around returning back to a diet that feels healthy and liberal. So certainly addressing food-related anxieties and fears with either your physicians, your dietitian, and a psychologist. We all feel very comfortable getting you the care that we can for that.
Do you mind if I just add?
Absolutely, please.
I think for me it's been very much a complementary approach. I definitely agree. I have tried diet on its own and it wasn't sufficient to control, so I always encourage patients to work with their practitioners and work with dietitians, work with their psychologists as well, because I think this is really a multidisciplinary approach to help get our diets as well as our diseases as well as the medications that we are on all stabilized together. I do also think this is very personalized. I myself suffer from multiple comorbidities, so I have a lot of functional gastrointestinal issues on top of my inflammatory bowel disease, which makes me a little bit more different. So I think, and sometimes more difficult in terms of diet. So I think that's why it's so important, because some of us might have an irritable bowel syndrome overlay on top of our inflammatory bowel disease, or we might have other GI issues. So I think that's why it's very, very important to work with our providers to really understand what kind of diet works for us and would work well with our medications.
That's great advice. What a wonderful panel we've had. So at this point, we're going to conclude our program. We want to thank everyone for joining us, and the outpouring and the registration and the number of people who've been a part of this program really exceeded our expectations, and you better believe we're going to do it again. I want to personally thank all of the different experts that we have sitting at this panel today for their contributions, and I also want to acknowledge the incredible staff from the Crohn's and Colitis Foundation as well as from the American Gastroenterological Association, and of course all of you for being part of this today. I hope that you've gotten the information that you need to understand how hard we're all working and how important it is that we all work together in order to conquer these diseases. And you created a list of questions for all the people who are contributing to your care so that you can advance the care of yourself and those you care about. Thank you very much.